So thank you for coming this afternoon. So this is the second corporate workshop in our series of 3, where we're really outlining the depth and breadth of what QIAGEN is doing from a molecular diagnostic to a bioinformatic to a life science standpoint. Today's talks will be around reducing time for clinical NGS test interpretation by 85%. So we'll have 2 speakers. Dr. Bita Litzenberger from QIAGEN and Dr. Ravi Cole will speak again as well. Dr. Litzenberger is the Global Product Director for Oncology. Prior to joining the QIAGEN team, Dr. Litzenberger led clinical decision support for several next-generation sequencing research protocols at MD Anderson Cancer Center. In this role, Dr. Litzenberger was responsible for providing alteration, interpretation, drug, and clinical trial options to clinicians. Dr. Litzenberger received her PhD in molecular genetics from the University of Aachen in Germany and was a National Cancer Institute-supported postdoctoral fellow in the Department of Clinical Cancer Prevention at MD Anderson Cancer Center. So thank you and welcome, Dr. Litzenberger.
Thank you so much for the introduction. Let's see if we can use this. So the approval of tumor-agnostic biomarkers such as MSI and the NTRK fusions, as well as the emerging biomarker tumor mutation burden, are significant drivers to adopt comprehensive cancer panels to detect all relevant biomarkers simultaneously in any cancer type. With the adoption of comprehensive cancer panels, though, you can generate now a larger number of variants and introduce novel biomarkers. So labs are challenged how to prioritize and discriminate relevant variants from those of unlikely clinical relevance. It is challenging to get immediate access to current information on clinically actionability for any cancer. And it is challenging to understand which therapies and clinical trials are appropriate. Further, how is it possible to interpret variants consistently and reproducibly according to the AMP and ACMG guidelines? And one of the challenges is to classify and interpret tumor mutation burden, and Dr. Kolhe will speak to it in the second half of this presentation. And the last thing is how to meet the turnaround time. So with increasing number of variants that are detected, oncologists are also facing with an increased number of treatments that are not covered under the guidelines. So this is a study that was recently done on 100,000 curated cases in our Knowledgebase. And an FDA-approved drug was the most applicable option in only 16% of the patient cases. For lung cancer, where a lot of approved therapies exist for targeted treatments, only 20 to 25% of the cases had a targeted treatment option covered under those guidelines. However, the majority of all patients require treatments that are not supported by those guidelines. Those are off-label therapies and investigational therapies. And therefore, treatment options need to be supported by the evidence to support and guide physician decisions. To interpret variants from NGS sequencing analysis from comprehensive cancer panels, QIAGEN offers a software and a service. QCI Interpret is a clinical decision support platform that allows molecular diagnostic labs to use and interact with the software to interpret variants and create actionable reports. On the other hand, we have QCI Precision Insights that's powered by NF1, which is a tailored service for interpretation of somatic variants, and it provides professionally interpreted report content and can work with the molecular diagnostics labs together to meet the turnaround time. I would like to take the opportunity to introduce each of the solutions. So QCI Interpret is a software platform that can be configured for each next generation sequencing assay for optimal variant interpretation. QCI Interpret intakes the output from the secondary analysis and prioritizes clinically relevant variants using configurable filters, applies automated AMP and ACMG-based classifications, and allows the user to have full transparency to the supporting evidence. The user also has access to the comprehensive QIAGEN Knowledgebase, which provides expertly curated alteration function, clinical cases, prognostic outcomes, treatment, and clinical trial information, which then can be used to generate a final report. The content of the knowledge base is presented in a user interface for each variant in context of the submitted diagnosis. And thus, this tailored content allows you to quickly answer important questions. What is the biological function of my mutation? Is it biological and clinically relevant? And what is the actionability? This platform allows the full automation from the VCF upload all the way to a final draft report. And that includes not only the upload of the VCF, including the patient metadata, it includes the prioritization of the clinically relevant variants. It can pre-select relevant variants, drugs, and clinical trials in a draft report, and thus reduces the hands-on time to draft and create the final report. So how can QCI Interpret provide meaningful, clinically actionable insights? QCI Interpret is powered by the QIAGEN Knowledgebase. It covers more than 21 million findings. What we mean with that is that those are variant disease associations or variant drug response associations, and that is covered from more than 30,000 publications, and we have more than 76,000 different disease types available to compute upon. The knowledge base is updated frequently. It's on a weekly basis to cope with the changing literature, with the changing availability on clinical trials, as well as with the changing FDA, EMA, or other drug labels. Further, QCI Interpret also provides 25 publicly or proprietary databases, which helps in assists in the classification of variants. The computation of the ACMG as well as the AMP guidelines is accomplished through a unique knowledge-based model. So in this model, we have expert curators that are PhD and MD trained biologists and medical doctors who read the scientific literature, look at the figures, tables, supplementary information, and put trial outcomes or functional data into a structured format. One of the formats is here. It's kind of an alteration clinically effect drug cancer type association. So this is not human readable. However, it provides a consistently structured format across various sources. And then we use natural language processing to provide a human readable output into the user interface of QCI Interpret that describes the essence of the functional experiment or the clinical trial outcome. So this allows us to create structured data across the various different databases that are out there. Once we have the structured format, we are able to provide and apply rule-based algorithms and compute the ACMG classification criteria as well as the AMP criteria on top of this data. So VCFs that are commonly the output from comprehensive cancer panel analysis contain thousands of variants. And QCI uses this, the knowledge base data to rapidly prioritize clinically relevant variants from those large data sets. Those variant filters can be customized according to the test-specific configurations, and once these test-specific configurations are set, it allows us to be consistent and scalable, prioritize relevant variants. Besides the automation of the variant priority, QCI also provides the automation of the pre-selection of alterations, treatments, and clinical trials in a draft report, again to allow the users to have reduced hands-on time to make selections, but rather focus on the scientific evidence that lays behind that selection. So how is an automated test presented in the user interface? When you open a test case in QCI Interpret, you'll be able to observe a list of variants that were prioritized and that now require deeper review. I want to first draw your attention here to filter settings. So this allows the customer to see what is the filtering cascade that was applied to narrow down the various filters, including descriptions of the filter settings. If a variant was pre-selected, you will be able to see the QCI status of the reportability as well as the QCI status of the assessment. So for each variant, QCI then provides a deeper assessment and transparent application of both the ACMG and AMP guidelines. So for those who would like to dig a little bit deeper into the variant classification, QCI provides the assessment including the underlying evidence. Further, in this assessment, you'll be also able to see the pre-selection of the treatments for a draft report. And again, there are references that are visible and can be seen so that you are able to understand the underlying evidence why QCI selected that treatment. Now, I mentioned that it's a software that is doing that. Of course, in this user interface, the user still has the full flexibility and control over the selection. That means if there's a disagreement between the expert and the software, there's flexibility to update the assessment and select or unselect treatment options. So this is a customizable final report output from QCI Interpret. It contains all relevant information that pertains to reporting of immunotherapies, if applicable, for tumor mutation burden and microcell instability, as well as the actionability and pathogenicity classification of a variant and its associated therapies. In subsequent pages, there is more information on the therapeutic implications, available clinical trials, and variant interpretation options, and those all can be customizable. So I want to show you some preliminary results of the accuracy of the automated actionability tiers. So this was a cross-comparison of more than 23,000 variants from 80 labs that were running 3,500 analysis across almost 350 indications. And the takeaway here is that the computed actionability was largely accepted by the user. And the other takeaway is that QCI is able to do that across a large number of indications, supporting the variant interpretation from comprehensive cancer panels. So in summary, QCI Interpret is an evidence-based clinical decision support solution that assists in the classification of variants and provides full transparency to the supporting evidence. It allows for sophisticated filtering to narrow down clinically relevant alterations. It can pre-select alterations, treatment, and clinical trials to reduce the hands-on time. TMB and MSI are supported for therapy and clinical trial matching. And to further scale the interpretation from comprehensive cancer panels, we have an API interface that allows the full integration to your workflow system and, and allow the scalability of such workflow. So I want to draw your attention to the second solution. It's QCI Precision Insights powered by NF1. It is a professional interpretation service that provides oncology-vetted clinical actionability and delivers relevant evidence and considers co-occurring variants for the prognosis, diagnostic, or therapeutic relevance and returns that information. QCI Precision Insights is powered by a knowledge base that comprises of more than 160,000 curated somatic alteration types across more than 1,000 cancer types and more than 1,900 somatic genes. So with that Precision Insights knowledge base, experts are able to provide clinical interpretation for all biomarkers simultaneously, including fusions, copy numbers, MSI, and TMB. It considers not just each variant by itself and interprets each variant by itself. The interpretation is done in context of the whole tumor mutational profile, and thus allows for return of information if co-occurring variants are affecting the prognosis, diagnosis, or therapeutic implication. The interpretation also provides a pathway-based treatment matching, and of course for each variant, the interpretation includes molecular impact clinical relevance that is reviewed by medical oncologists. So QCI Precision Insights draws back upon NF1 team that has more than 1 decade of experience in working directly with the oncologists and patients to provide relevant treatment options. They have expanded their clinical interpretation service in 2012 to large hospital systems and commercial laboratories, and since then has expanded their interpretation service across a wide customer base and providing molecular-based matches, patient-specific evidence-driven therapy options. In 2019, NF1 joins QIAGEN while continuing to serve its diverse client bases. So because this team can draw upon more than 10 years of experience in interpreting variants, somatic variants, this experienced team of PhD scientists and is supported by practicing oncologists to return clinical information. It draws upon this proprietary database as well, which contains now more than 175,000 patient cases comprising of more than 1,000 different cancer types. The service is built upon a database that can be integrated with any bioinformatics solution and can provide actionable insights for any panel and any platform. So QCI Precision Insights enables the insights from comprehensive genomic profiling, not only from next generation sequencing, but also is able to incorporate in a patient report the analysis from other assay types, copy number analysis, FISH, RT-PCR, and IHC. So what is presented on a comprehensive report? The interpretation clearly differentiates clinically relevant alterations from other alterations. It is differentiating it based on the AMP tiers. And for each patient case, there is also a clinical guideline information present that describes the variant in context of the diagnosis. As I mentioned before, each variant is not interpreted separately, but as a conjunction in the tumor mutational profile, and therefore the effects of co-occurring variants on prognostic, diagnostic relevance on drug sensitivity is taken into consideration with appropriate level of evidence. For each variant, though, biological and clinical insights are given, including disease-specific biological and clinical evidence and the effect on drug sensitivity and drug resistance. I would like to highlight that customers using Precision Insights have reduced their case preparation by 85 to 90% using that interpretation service. So in summary, QIAGEN Clinical Insight has a flexible solution to analyze and interpret variants from comprehensive cancer panels. QCI Interpret is a software platform that assists in the variant classification, and QCI Precision Insights is a professional interpretation service which provides you with the variant interpretation. Both services are built on a robust platform and that allows for seamless integration and a scalable solution to meet your turnaround times. So with that, I will hand over to Dr. Kolhe. Please visit us at our booth, number 3113. Okay.
Thank you, Dr. Litzenberger. So our next speaker is Dr. Ravi Cole. Dr. Cole is an associate professor in the Department of Pathology at the Augusta University in Augusta, Georgia. He divides his time between directing molecular pathology, cytogenetics, breast pathology, teaching, and research. He is the CLIA lab director for the Georgia Esoteric and Molecular Labs, and also serves as the medical director for the cytogenetics lab. In 2018, his laboratory was granted the NCI Match designation. And thank you very much, Dr. Cole. Welcome.
Thank you, Arnold. Thank you, Jonathan. And we had said that what I'm going to do here is go over some of the work we have done with QCI. And we have done a lot of work with QCI. We've done work in three aspects. So we used QCI as a solution for QIAGEN sequencing through GeneReader, which is streamlined. We have used QCI on QIAseq library prep, which was sequenced on another sequencer but used QCI as a solution. And we have also evaluated QCI as a bioinformatics solution for a different panel on a different sequencer. So I'm going to present our experience with, I already presented one with the QCI on GeneReader, and I'm going to present with the QIAseq and another panel in our lab. So I want to focus on TMB because I think it is challenging in a clinical lab on how we are looking at TMB, especially coming to the conclusion of how we should be calculating TMB and what are the opportunities in there, especially the interpretation part. So I'm Ravi Cole. I'm a pathologist at the Medical College of Georgia. I practice molecular and breast pathology. These are my relevant disclosure with the content of the talk. This is a QIAGEN sponsored event, but most importantly, what I'm going to say here is my personal opinion and does not reflect opinions of my collaborators or especially my employer. So I work in a lab called Georgia Esoteric and Molecular Lab. It's a CLIA lab owned by the state of Georgia for high complexity testing. And we have a variety of panels and platforms, something as simple as NGS to something very complex like vector multiplex imaging for patient care for either clinical care or clinical trial settings. So I would like to say we are relatively advanced NGS users at this stage, 5 to 7 years of experience, small, big panel. And just to give you an example of the panels which we have clinically validated and made available for our pathologists or oncologists, there's a whole array of them. And each and every time when you validate something like this, you end up in a challenge of validating the bioinformatics part of those panels for interpretation. As Jonathan said, we are an NCI designated lab, so we do get a lot of samples for reference testing. But for this particular talk, I want to go into more deep about what we're really trying to test for immuno-oncology, especially focused on TMB. And then I want to give you insights on the QCI, how we are using it, and what it looks like. So when you're looking at the cancer immunity cycle, there are so many things happening and so many things that are targeted in a trial setting or pre-trial setting these days. But the entire focus at this moment is on the last stage of killing these cancer cells, especially with the recognition by the T cells. So if you want to just look at the biomarker picture for immuno-oncology, it is a huge amount of biomarkers going on, especially at this moment dominated by PD-L1. And if you just want to focus on TMB, TMB is an extremely small portion of this biomarker landscape just for immuno-oncology. So for those people who don't know what TMB is, it's nothing but number of somatic mutations per area of the genome. It might look simple, but that's the definition we started with. The idea is the somatic mutations accumulate over the time, and they're definitely different from germline and maybe tumor or patient specific. These mutations are expressed either DNA, RNA, and then get recognized by immune cells as new antigens. So that's our hypothesis with TMB and new antigens. So why is TMB important? Probably I'm going to blame on this NEJM article which came out in January of 2019. An updated version of this particular trial is, I think is reported in another NEJM article last week of September. So what Dr. Hellman and his group showed that this was probably one of the only trial where they have combined two drugs of immuno-oncology. So IO versus chemotherapy. So they've combined Nivo and Ipi, and they compared with chemotherapy. And the idea at that time was the definition of TMB. So the thing which highlighted was the definition of TMB was definition of high TMB was 10 mutations per megabase. Apart from that definition, one of the most interesting things for me as a pathologist in this article was the patients who had PD-L1 expression less than 1% in this particular trial setting had a phenomenal response, of progression-free survival response for in a combination of Nivo plus Ipi versus chemotherapy. So this is where it shows, and this pretty much defines why we are doing TMB, because all these years we do PD-L1 IHC and identify these patients in our lab, and these patients are then put on some kind of immuno-oncology therapy. But here what they're showing is even if you have less than 1% PD-L1 IHC, which basically in definition is negative PD-L1, these patients had a phenomenal response for IO-IO combination. But the challenge at that time and still is that the definition of at least 10 mutations per megabase is defined as high TMB in these groups of patients. So the other reason why everyone is interested in TMB because it's a pan-cancer biomarker. It's not related to one cancer, but pretty much every other tumor type has some kind of somatic mutations which can be calculated. But the challenge is, as you can see here, the definition of high and low TMB is way different from something as AML versus melanoma, because these are hot versus cold tumors. Before I begin into the data, I just want to review this article quickly and give you an idea where the field is going and why we are doing this. So this is a nice cancer review article which talks about the identification of immune-related new antigens. So on a cancer cell, you have these new antigens which are identified by T cells as a beginning process of immune-based treatment options. The challenge with this is all these years we were focused on the last part of this puzzle, which is the PD-L1 IHC. And now we're trying to see that we're pretty much skipping on in between four processes and going directly to the DNA and try to see if we can look at the TMB, which could be used as a surrogate for all these new antigens expressed in between. So that's one of my challenge of accepting TMB as a true biomarker, because there's a whole bunch of other activities, especially the RNA proteasome, transcriptional associated, and the MHC class 1. So we are not even looking at any of these. All these years we're focused on the surface expressed new antigens, and now we are focusing on the somatic mutations in the DNA. So that's number one. The number two is, how are we looking at each and every of these processes? So if we just want to focus on the somatic mutation, we are doing it by mutational profiling, and ideally these mutation profiling need to be done either by whole genome or whole exome. And all this exercise in our lab is, can we find an appropriate panel which will be a true surrogate for whole genome or whole exome? So we are looking at just the beginning of new antigens, and the second challenge is we are looking at a surrogate gene panel in comparison to whole genome or whole exome. So those are the two challenges to begin with the TMB. So this is my personal summary on TMB. It is the most sought out biomarker of this decade. I know it's not that much discussed at AMP, but if you go to ASCO or AACR, there's a lot of discussion and talks on TMB. It is becoming the most expensive biomarker. I mean, IHC costs maybe $30, $40, while TMB, especially blood-based TMB, is going to be really expensive. I personally think it's very much industry-driven, because by the time half of us knew what exactly TMB was, there were at least 30 to 40 clinical trials in place. And I think that is the real challenge we are facing as a lab, because all our oncologists go to ASCO meetings and they get pushed by some biomarker, and then they come back in the practice and they say, hey, I want this biomarker. I want MSI on each and every sample. I want TMB on each and every sample, tumor sample. So what in our practice we call as a post-ASCO syndrome. And the problem or challenge is we are not ready as a lab in any setting, a molecular or surgical pathology setting. And I think this is why it needs to be discussed a lot more, so we will have a lot more clarity on what TMB is. As I earlier mentioned, I personally think it's still a surrogate. We're not really looking at new antigens. We are looking at TMB as a surrogate. It is still a small piece of puzzle for new antigens, but it is the most impactful biomarker for IO, because I've seen that data in published and unpublished data, and TMB definitely makes a difference in outcomes of these patients. The challenge is the cutoff. So what exactly is high TMB and low TMB is a discussion for a whole different time, but it is definitely here to stay. So for us, the important question is to TMB or not to TMB, and there are a lot of labs who are actually at this stage deciding whether they want to bring in panels which will identify TMB or not. For them, I personally think it is time to get started on TMB. It is a great surrogate marker. The trial data, especially the progression-free survival, looks good. And as somebody who works in a biomarker lab, it is a good start. I mean, versus putting patients blindly on IO-based therapy, which is very expensive. So how do you evaluate TMB as a biomarker? We have done decent work on this. So we identified there are three challenges. So one is the size and content of the panel, which would be considered a true surrogate for whole exome sequencing. The second is the bioinformatics module for the TMB calculation, which is extremely important because I'll show you in a minute what we have done, and then one mutations here and there, the value changes. And finally, the most important piece of this is how are we going to interpret these scores? Is it going to be a TMB score, or are you going to call it TMB value? Because I personally think we should not be saying out it's TMB high or low purely because it's a phenotype based. At this moment, I report only as a value, and then it goes into a tumor board discussion to see what tumor type is and what trial they will be doing, and based on that, it gets labeled as TMB high or TMB low. And if you are in the TMB business, this is a really phenomenal paper from Friends of Cancer Research, who have really gone through each and every granular detail of TMB calculation and issues with the TMB calculation, going from sample collection to the TMB score. Unfortunately for us, this came out after all the work we have done, so we have felt all the pain which is published in this paper. The second issue with is TMB is the cold versus hot tumors. So I showed you that the graph where there are tumors on the lower side which are very low on TMB, the tumors which are on the high side of the TMB. So you cannot say a TMB of a 5 is low TMB in breast, because the TMB values in breast cancers are very low. But a TMB of 5 will be a low in melanoma or non-small cell carcinomas because they are very hot tumors or they have high TMBs. So that's the difference between hot and cold tumors. The challenge is fresh versus FFPE or cell-free DNA. If you're using a fresh tissue, the exact same tissue, if you put it in FFPE, the TMB value changes, and that's a huge challenge we're going to come across when you'll have a TMB value on a surgical pathology specimen at the time of diagnosis, and when these patients starts to go on a cell-free DNA TMB, there's going to be a huge change, a huge difference between original TMB value on a fresh or FFP tissue and a cell-free TMB value. Tumor enrichment, tumor heterogeneity for TMB is real. There are very good publications on this. Those are the real challenges apart from all the earlier thing I mentioned. But at least one thing we have settled down on is the genomic region covered for TMB identification. So we know at this moment that if you're using a panel as a surrogate for whole exome sequencing, the panel size has to be 1.2 to 2 megabase. You cannot go below 1.2 megabase. And there's a good amount of very validated data to show that, and we have actually had to deal with it because our current panel is 0.5 megabase, and we realized that this is absolutely not a true surrogate. The content of the panel definitely matters. I think people need to start spending more time in not just increasing the number of the genes or increasing the size of the panel, but what exactly goes in those panels for TMB calculation. And at the end, how are you sequencing? What's the depth of sequencing? And finally, what is contributing towards the TMB calculation? So this was the article I think we referred earlier also, which pretty much goes in detail about different panel sizes and the whole exome sequencing comparison, and which pretty much talk about 1.1 or 1.2 to 2.2 megabase is an ideal size for a panel as a surrogate for whole exome sequencing. Finally, the pipeline parameters for TMB calculation, the status of germline variants, are you deducting the driver mutations, how many and what variant callers you're using, synonymous versus non-synonymous, what's the allele frequency. I gave a talk yesterday in the reference material forum, and one of the speakers there presented a really good data that if your allele frequency fraction, in your setting, if you keep on going below 5%, the TMB value increases. It was really nice to understand that concept, but the challenge is, does that high value of TMB really means anything clinically? Because most of the trials are done with that particular cutoff. So things like that definitely makes a difference in your TMB calculation. So what we have done in the lab is we have used two panels, QIAseq 486 gene TMB panel and the TST170 panel, which is our standard panel in the lab for comprehensive genomic testing. And then we have used QCI for both of them to look at the TMB value. So before I go that, I just want to show you that we have gone through the exercise of pushing our data through a huge range of bioinformatics solutions. So when I say this really works, that it doesn't work, we have spent literally hours and hours, if not months, with our TST170 data with pretty much every other available solution, and identified what works best for us as a clinical reporting solution. And this was more than 2 years ago. I think this work is continuation, and this is what a paranoia of pathologists look like. Because when we started reporting out, I think we were not just happy with one solution. We wanted to make sure that what we were reporting was truly the correct one, and that's why we ended up collaborating with this many groups. So the QIAseq TMB panel, the 486 gene, covers exonic regions for all the 486 genes. And when I say about the content of the panel, you really have to go and look what are the different processes in the panel and the genes are covering in the panel, and this is what is covered, which relates to the original review articles which I mentioned. I think we really need to look at the all processes in identification of immune-related new antigens, and then make sure that the content of your panel actually covers, if not all of these processes, so that whatever TMB calculation you're getting at the end is a meaningful, not just some number. So the QIAGEN TMB panel versus exome data, the TMB correlation looks really great. The size is around 1.4 MB. And this is just to show that the TMB cutoff from 8 to 20 and its correlation with the exome, the really nice positive predictive and negative predictive value for that particular 486 gene panel. So what we did post whole exome comparison was we had a two-site evaluation for that particular panel using QCI for TMB, MSI, CNVs, SNVs, and indel. And you have to understand that all these do, at the end of the day, get contributed towards the calculation of the TMB. So these are not individual values and numbers. Definitely, we need them for targetable, actionable drugs, but these do contribute towards the calculation of TMB. So I'm just going to focus on the results which are TMB focused. This was the two-site correlation with the great correlation of a whole range of TMB values on the 486 gene panel between the two labs on the two sites. Also, we compared all these samples with Foundation 1, and it did show a decent correlation, and this was purely because the Foundation 1 panel, if you guys are not aware, is around 0.8 megabase, which is actually lower than the threshold. Ideally, we would like to see for TMB calculation between 1.1 and 2.2 megabase. The second part of the project with QCI was with TST-170 panel, which we have in the lab. The objective of this project, and then this is a lot of work done both at QIAGEN as well as in my lab with one of the postdoctoral fellow, is to assess and validate QCI as a independent software, because you could remember earlier I told you we have worked with QCI in 3 different settings. The first one was with the gene reader, the second one was with the QIAseq library prep, and this is the third one where we're using independent panel by Illumina, which is TST-170 on an Illumina sequencer, and then we'll be using that output on a QCI. These were our 3 goals: to assess the QCI as an independent reporting solution, and check all these samples, how do they perform for the tiers. So I think we have more than 80 cases run on this at this moment. I'm just showing data on 52. So we use an array of tumor samples. So these are all clinical samples which were retrospectively looked at. So we have issued clinical reports on all these samples. So we went from we used gliomas, melanomas, something as rare as liposarcomas, a few AML cases which we have used TST-170 on. And just to summarize, the original analysis was on Illumina's TrueSight 170 app. So Illumina has a primary alignment and app in BaseSpace, which we use primarily to create all the VCF, and those VCFs were used in the QCI for secondary analysis. And then in the end, we ended up looking at more than 500 alterations, mostly on SNVs, in-frame deletions, CNVs, and fusions. And the way we have set up the pipeline and the filtering is probably dictates what you'll end up going to get at. So, and when I say this, I mean, you saw that we have worked with more than 10 plus bioinformatics solutions. Filtering your bioinformatics pipeline is the most critical aspect of your NGS validation. You're going to end up with so much data, especially with the panel size increasing, that if you don't pay that much attention in the validation cohort for setting your filters, irrespective of what solutions you're using. You end up spending a lot more time in doing the interpretation. So if you ask me what is the one thing you'll have to work on is the setting up your filters for the QCI, or any bioinformatics solutions which you'll end up using during your validation. So the way we did was, again, this was to look at all these in retrospective setting. So the variant which were passed by upstream at allele frequency of 5, get rid of the polymorphism, the biological context, and then identify the predicted and deleterious variants, and then you end up looking at the final list of relevant variants. So I think the previous speaker did show this, but I also again want to show that this is very common in a comprehensive genomic panel to start with something as 2,000 plus variants, and now we are using a bigger panel of TSO 500, which again, the number of total variants goes very high. But this is where the filtering comes in place. With a good filter, good validated filter, you can go from 2,000 plus to around 49 to look at. And based on our aim and the way we have set up the study, we looked at each and every tier 1 and tier 2 variant and compared with our existing solution to make sure that the calls made by QCI were accurate in those two categories. This is just an example how a particular variant and the computed classification, which is automated, will look like. So this is a glioblastoma with IDH1, R132H type variant, and then which will get classified as a tier 1A. And then you'll also see what was the reason for this classification, and you'll get a chance to look at these and review this in QCI. This is another example of lung adenocarcinoma with EGFR variant, which is also getting classified as tier 1A. And then you'll have all the evidence which you need to look at and confirm the classification with QCI. And this is where the validation is critical, because this is where you want to spend your earlier time and make sure your tier 1 and tier 2 are classified 100% correctly, and that will end up saving a lot of your time during actual sign-out. So the way we defined the true positives and true negative, false positive and false negative in the study was purely based on how the automated tier 1 and tier 2 calls were made by QCI, and then the calls made by us retrospectively on our previous or current solution. So true positive, true negative was something which was computed at tier 3 and were accepted by us. And then false positive, something which was computed as tier 1 or tier 2, and then, but we were calling it as a tier 3 in our solution. And false negative was computed tier 3 classification, and we had to change it to tier 1 or tier 2. So without going into much jargon details, this is how the data looks like. For 500 plus variants, we looked at 52 different samples on TST 170. So we got an accuracy of 100% on tier 1 and 96% in tier 2. And we'll go over these 6 VUS in a second with a specificity of 99.7%. And that really has helped us to strengthen our belief that QCI can be a really great standalone solution irrespective of what sequencing platform or panel you'll be using. So let's look at the 6 variant calls which were different. And this relates to the, you have to remember all these cases which we have used in the study were classified and signed out somewhere 2 to 3 years ago. So there is a definite change in classifications purely based on the addition of new evidence. And this is what it relates to. So for example, the TERT mutation or the NRAS E63K mutations or TP53 mutations or ATR mutations or changes now with the new functional studies or new emerging therapies are reclassified in QCI Knowledgebase versus they were called as VUS earlier. So having an up-to-date knowledge base, I think the previous speakers explained, or I think is a weekly updating, that definitely makes a huge or adds a huge difference to your sign-out. So going to the TMB or the biomarkers, so this is our earlier attempt to look at a TMB along with other immune-based biomarkers in a QCI. So this is how a TMB would be identified, especially this is a colorectal cancer, the phenotype, and it will be identified as a tier 2C pathogenic because the TMB score was 68.5 mutations per megabase. And then you'll have the particular guidelines obviously at this moment are with non-small cell, which could be used for tier 2C. So in the end, as I said, we have really worked hard on multiple bioinformatics pipeline, and even though this is a QIAGEN-sponsored event, I personally would like to say that QCI is probably the most, one of the best reporting solutions we have worked with. There are a few things definitely needs to be changed, done, and I think they're working on. And now with the addition of their knowledge base from N of 1, it is going to be significantly changing the way we'll be reporting out the next generation sequencing panels. It doesn't matter if it's small or they're big. The automated classification, especially the tier 1 and tier 2, which we saw, were with accuracy of 100 to 99%, and I think that's where the validation would come in. And then the third point was the QCI confidently interprets variants according to the AM guidelines. And then lastly, the point which I began with is it can be truly used as an independent reporting solution irrespective of library or sequencing platform. So I have a couple of slides, and I think this is outside or independent of what reporting solution, what panel you're going to use. The challenge is going to be with the clinical interpretation of TMB score. So just to give you an example, I think Jonathan had asked this question about earlier in the first talk. So these are the number of TMB-based trials going on right now. So just if you're looking at these trials, I'll come back to that, but this is a great MSK-based paper which shows that not only TMB is tumor-specific, it's also patient-specific. So we cannot club a value of TMB universally across all the tumor types. Just to give you an example, let's say if you're looking at this particular Checkmate 263 trial, which was done on first-line non-small cell, in that particular panel, in that particular trial, the platform was whole exome sequencing. The cutoff for these mutations are low, medium, and high, and the drug is Nivo. And these things really need to apply when you're signing out or doing the clinical interpretation of the TMB score. So I think I would suggest that the interpreting solutions should not be putting out the high, medium, or low numbers or values, rather than just putting out the scores and let the lab or the signing out pathologist or the oncologist take that number and make a clinical decision for the patient care. So this could pretty well be for each and every trial based on what phenotype it is and what drug the oncologist wants to treat, and the TMB value and score need to be, the interpretation should be done based on that. So again, I want to summarize or end with this picture that we are still looking at one small piece of the puzzle, but it's a true surrogate marker. We are looking at gene panels as a surrogate for whole exome sequencing. And I want to thank the people in the lab who actually do all the work, and I get credit. So this is Ashish, Barb, and Alka. These are the lab techs who are actively involved with TST 170. These are the postdoctoral fellows. One of them is working with the QCI project. And then we have a molecular pathology fellow from Medical College of Kenya, Nairobi, who's also getting used to this. I also would like to thank our QIAGEN collaborators. I think there's a lot of work for putting all this data together, so thank you. But I want to end with this picture. I usually don't show family pictures, but I think I spend a lot of time in my office training machines to look at our genes, but I think it's time for my own genes to learn how to train these machines. So this is my daughter, Hannah. She's 8 years old and second grader. She just started to learn how to code, and we got this book last week for her. So she's a happy coder. Thank you.
We've got a minute or two for questions. Any questions? Well, thank you very much to Dr. Blitzenberger and Dr. Cole for very informative talks, and greatly appreciate their time today. Thank you.
QIAGEN.
Sample to insight.